Right, so I have, I think, about 25 minutes to talk about some GI cases that I think are unusual, that you probably learn something from this workshop. No conflict of interest regarding this presentation. So this is going to be the outline of my presentation. I'll do 3 case studies to have some unusual GI presentation, need for urgent intervention and appropriate advice to your patient, and I'll highlight one endoscopic intervention. So this is the first case scenario. 30-year-old female with intestinal obstruction, had laparotomy done somewhere 2019. If you look at the history that I've shown here, she had several surgeries. She had a second, third laparotomy on account of pelvic abscess. Resection of part of the small bowel was done, was referred to a second hospital for a 4th laparotomy, where he had 2 perforations, iliac and anterior rectum. He also had a resection of the perforation site, which was done, and anastomosis also performed for this patient. Later on, they had to do a loop colostomy for the patient to continue duties. If you look at this, while we are waiting the histology, what diagnosis comes to mind? If you had seen a patient who has had this repeated surgeries, breaking down pelvic abscesses, is there anything that comes to mind? Crohn's disease. So it looks like my lecture can actually end. It's interesting to hear that young guys like you put to say Crohn's disease. And that's exactly what it is. And this patient kept going in and out with the surgeries until the histology actually came in. Okay, so this is very important, especially in the past medical history. If you had a patient who had intermittent mouth ulcers at age 18, which became persistent from age 25, bloody stools, crampy abdominal pain, general joint pain, with severe lower back pain, to the extent that the neurosurgeon had to come in, and MRI was done, that was normal, and just said to do physiotherapy. There was a history of had repeated blood transfusions and had a right hemicolectomy done at age 21 years. And so the Crohn's disease diagnosis was not made until the histology came up. So I thought it's something that we should all think about. Crohn's disease is not a disease in the Western world, it is in Ghana as well. And as you see your patient who have chronic diarrhea, let it be part of your differential diagnosis and work out. So this same patient did a self-referral. Now people go online and check on where they can get a vessel, did a self-referral to my facility. We retrieved the histology. It's interesting, the histology had been there for a long time. I don't want to say how long, but it was interesting. We had to go all the place to actually get it. And it was actually shown that it's Crohn's ileitis from the initial resection that was done. So this is the patient at presentation. What am I not doing right? Hello, hello, hello. I should be another one. Hello? I should use this one? Does it come on? I'm not sure how it comes. Hello? Hello? I think this is better. Alright, so this is the patient at presentation. And as you can see, significant wasting, hair loss, this is the stoma side. She weighed 55 kg, so I described all the things here, not pre-arterial, respiratory system, cardiovascular, unremarkable, except for the stoma site, which was quite uncomfortable. We got it cleaned up and got some stoma bags for her to live with. So with our labs, we went through all the key labs. These were all normal. I think the key thing was the vitamin B12. And if you remember, they did a resection involving the terminal ileum. So this was something that had to be followed. So the low vitamin D also has its own systemic effect, which was also addressed as well. So the patient was put on prednisone. In fact, the discussion was to do biologic therapy, but money was a problem. So we had to put in a system in place to see how we can get the money for that individual. Azathioprine and some PPI initially. There was a remarkable response in terms of a pain at the right iliac for 24 hours. We scaled up the azathioprine to 75 within 2 weeks after reviewing the liver chemistry. So we're actually preparing this patient for biologic therapy And if you look at it, all these things were negative. Fundraising to get infliximab was a challenge. After writing a few letters, so doctors be prepared to write letters of support for your patient. We were able to get the funds, and then we started the treatment for this. Before we started, I think on this date, she came in with severe right earlier prostate, fever, temperature of 38. Right earlier prostate maps. I mean, with such an abdomen that has been entered over 5 times, with the mass on the right side, I think you're not going to open up again. We did our markers, and this was CRP was more than 300, fecal cow protection 390. This is an important marker, especially when you are suspecting that somebody may have a GI pathology and you think that it's irritable bowel syndrome. I think it's a basic thing that you can do for your patient. It comes out normal based on your history and other than probably they would help with putting together a diagnosis of irritable bowel syndrome. Here, it was very high, all in support of an inflammation in the intestine. We're able to start on infliximab. I'm not taking you through the whole regimen, but the induction dose of time 0, 2 weeks and 6 weeks was done. Was weighing 60 kg, so we're doing 300 mg, 5 mg per kg to continue 8 weekly. But as the time frame is maintained, as part later you learn about the sonic study and why you should still keep the time frame. But that's not this lecture. So her vitamin B12 level actually normalized following the injections. Patient was in remission. And it's interesting that I would want to know who can guess a new complaint here. Anyone? Every answer is okay. Just say, what's a new complaint? She wants to have a baby. That's a good one. that was one of the issues. That was one, but the main complaint. What?
The stomach when touched.
The stomach side, no? Okay. Weight gain. So this was the same patient who came in with. This was the same patient who came in initially, and having been on therapy for a new complaint is now weight gain. So that's quite interesting. You're able to put a smile on your patient. So this was the after treatment and before treatment. Just a few words on that. I think there's a challenge in our environment. What we need to know is that it's not a disease of high-income countries. Well, it's uncommon in sub-Saharan Africa as it's said, but I don't think so. I think it's an issue of knowledge and lack of diagnostics. The more we get to know, I remember when somebody said ulcerative colitis, you're likely to fail your exams. Because we were not doing a lot of colonoscopies. Histology was not popular. But since we started doing it, I have about 15 Crohn's disease patients, which is very unusual. As for ulcerative colitis, I can't count. And patients have actually benefited. So what I'm just trying to say is that, in my opinion, it's not true. It's because of lack of knowledge and diagnostics especially. Okay? Uncommon. Again, because of inaccessible treatment, which I've already highlighted. If you look at the global picture in terms of inflammatory bowel disease, we are reporting the lowest. But I'm sure with time, we will be reporting similar to other places. And Ghana, somewhere here in the blue, less than 20 per 100,000 population. Maybe if we go further, we'll see into the surgeons, that of patients who have had repeated antibiotics over the past some years, maybe ulcerative colitis or Crohn's, and we need to really look out for them. So from most studies, what is shown is that UC diagnosis takes an average of about 2 to 3 years. It tells you how much antibiotic various causes they've gone through. For Crohn's disease, about 6 to 10 years before they are diagnosed in our environment. And I think that when you live here, you should be able to change that by asking for these key investigations for them. The other thing is that I think we need to increase awareness. We need to share the data on inflammatory bowel disease in our environment, which some of us are actually doing, so that people will know that it's also there. Again, clinician hesitancy in diagnosing inflammatory bowel disease. If you ask for differential, probably it's the last thing that will be mentioned, but sometimes it's actually the top, because based on your history, that is what it is. But you feel like saying inflammatory bowel disease first doesn't make sense. So please, let's look at it as we have in our differential. To support it. The other thing is hesitancy to call inflammatory bowel disease. We don't have dedicated GI pathologists. So usually the diagnosis is non-specific colitis, infective colitis, but they have described vividly everything about ulcerative colitis or Crohn's disease. So you need to also have that knowledge to be able to say this is the case and then help your patient. In terms of infection that mimic inflammatory bowel disease, these are all here: tuberculosis and viruses, schistosomiasis, shigellosis. We need to look at them, but also think beyond them and know that it could be inflammatory bowel disease. still distribution of gastroenterologists, still distribution of endoscopy services. We are all aware of that, but that should not prevent you from making a diagnosis of Crohn's disease. First, think that it could be, and then the other things will follow. But if you don't put in your differentials at all, then the workup certainly will not address that. So this is going to be my last step on this case. And what I'm saying now, this is the 4 epidemiological disease evolution. If you look at the Western world, from the 1750s, they went through the phase of what we call emergence, acceleration in incidence. Emergence is where you see sporadic cases, and we are more or less reporting sporadic cases. But I think they are there because of the challenge we are not yet over. And it was projected actually that as we get into the 2020s, we are going to have acceleration in incidence. And I think that is what has happened. For most of the specialist centers, we are seeing a lot of the inflammatory bowel disease. So we know that is available, or the diagnostics are available, the specialists are here, and refer them to the appropriate centers so they can get the best of care. So this is my patient who is doing a lot of advocacy on IBD, and she's happy we share these pictures all over. We actually put together what we call the IBD Foundation Ghana, which is trying to work around it. Right, so we'll go to the next case study. A 33-year-old non who presented with a year history of progressive darkening in the palm. He works at the bank, right at where they count the money, so he had actually attributed it to probably counting money. I didn't know that if you have a lot of money, your palm will be black. I'm sure most of us will still choose it. Okay, so symptoms gradually progressed to involve the knuckles and both soles of his feet. He had associated symptoms which we call, which here was anorexia, dysgeusia, easy fatigability, and dizziness. He also talked about the fact he lost some weight. He talked about 20 kg, but we were able to estimate it to about 10 kg, but this was his presentation of it. He had received 2 units of blood on account of symptomatic anemia 5 months prior to his presentation. He had no known chronic illness, not on any medication, had not had any gastric surgeries or gastrointestinal surgery. His family and social histories were unremarkable. He had no dietary restrictions as well. On examination, we have this patient who has hyperpigmentation involving the hands, fingers, legs, soles of feet, hair loss, and other mucosa examination were normal. Neurologic examination, systemic, everything was fine, except for an HB of 5.9 MCV, which was also high. All the other examinations were fine. I think initially they were suspecting Addison's disease, so the cortisol, ACTH levels that were done were also normal. Of course, with this HB, blood film comes with it. So blood film described anisopoikilocytosis with moderate hyperchromasia, multiple hypersegmented neutrophils, and eosinophilia. Bone marrow also showed all these features with an addition of the hypersegmented neutrophil. At this point, what's the diagnosis? Anyone? Pernicious anemia? Okay? Anemia? Okay, so that looks anemia from B12 deficiency. We will establish whether it's pernicious or not. So we'll go to that. But you're not out of place at all. You're talking about the fact that you have vitamin B12 deficiency driving this anemia. So we did antibody screen, prioritized cell intrinsic, those were all negative. So you will not put down pernicious. However, it's B12 deficiency. CT scan of the abdomen and burial fluid to see if there's any damage to the area integrity by B12 will be low. These were all normal. We did stool examination. Any reason why you want to do stool examination in investigating a patient who has B12 deficiency? Diffluobotrium latum. We all know that that's all. It's the cause of B12 deficiency, which is a worm infestation. So if it's there, we'll treat that and the B12 will normal. But this was also negative. I'm sure most of you have forgotten your parasitology. We did endoscopy, biopsy the gastric mucosa. It didn't come out with any. That's the non-specific inflammation of the gastric mucosa, possibly attributed to H. pylori infection. The B12, a diagnosis of vitamin B12, possibly from H. pylori infection, is what was arrived at. The patient was put on B12, H. pylori eradication done successfully. Within 2 weeks of the therapy, the hyperpigmentation started improving significantly. Vitamin B12 level actually normalized. There was a progressive improvement of both the palmar and the plantar hyperpigmentation. I will just not speak about everything here, but if you look at HB here. We started from 5.9, 8.6. We only did one transfusion here, initially when he came because he was symptomatic. And from then onwards, it kept rising until 3 months was 13.3. The key thing we did was the vitamin B12 supplementation. If you look at the MCV, which is also another important, so MCV here, 102, 96, and it came to 7. And it's consistent with the diagnosis from the beginning and reversal in terms of as we normalize the vitamin B12 level. So this is our patient representation. This is that part. So we're thinking of what we did. When therapy was started, this is 1 month and this is 3 months. And come back to normal. This was the sole of the feet, also here, progressively through. So just saying that vitamin B12 is something we need to also look out for. And usually the diagnosis is missed. If you don't think about it, you will not make a diagnosis until you finally come in with a neurologic deficit, which you know is subacute combined degeneration of the cord. You don't want your patient to get to that level. So we did the eradication, and then this patient B12 at normal, never gone back. We haven't done any other therapy. We followed this patient probably for about 2 or 3 years, and there hasn't been any issue at all. So think about B12 in your patient who. This has been published in the Pan-African Medical Journal. You can follow to read it up in full. And then my last case, do I still have time? Good, perfect. So my last case is just going to highlight on some of the decisions that, or the advice that we give to patients. So this is a young man, 24-year-old. I struggled to understand how he swallowed a toothpick. Said he was saddled in the morning, he was playing around the hood. I really struggled to understand. And he swallowed the toothpick. 3 months earlier. So he went to see the doctor, and guess what the doctor told him? That the toothpick would pass through the feces, so they shouldn't do anything. So he came to me not with a complaint of having swallowed toothpick, but with a complaint of abdominal pain. And never even mentioned the toothpick that had been swallowed. More or less was an open access endoscopy. It wasn't my patient primarily, but was referred to my endoscopy unit to have an endoscopy done for this patient. I went in and I saw very interesting images which I will show you. And myself, for the first time, I was surprised what I'm seeing. So we did some washing out. So this is an endoscopy, this is antrum. And for me, that was my first time since I was wondering what it could be. So I had to, because I usually do propofol sedation and all that for the patient. So I had to take the patient back to go and relax, come up fully, to take another history to understand. So, because the complaint was abdominal pain for 3 months. That's what the patient came in with. So the patient went into, but I went back, and I said, so is there something that, and so 3 months ago we swallowed the toothpick. And so, myself still, I wasn't confused, but I didn't know that when the toothpick gets in, it gets coated and appears like this. We washed and washed, it wasn't cleaned up. So we prepared with his consent and everything, we decided to go. So this was a removal of the toothpick in there. And this that we have also published as well. But I think I hope it plays. And then I will try and round up. I should advance? Okay, good. Excellent. I think we can't watch all of it, so I'll just reduce. Oh, it's more. Sorry. It was playing, but it's a bit long, so I wanted to just cut it and just say the salient thing out of it. Not too long, since I've not been signaled it's 5 minutes here, it's not 5 minutes, so we went in with all the discussion. Before we did it, we did not do it on the next day because we didn't have what it takes to actually get it removed, so I had to go and get the grasping faucet properly. Got x-rays to make sure there's no perforation before our procedure. And then after, of course, we followed up with the procedure. This has also been published, so I'll share with you. So this is to invite some of you to join gastroenterology.
We are coming.
And I think the other thing I would also want to add before, as we watch these videos, if you are sending a patient to a center for a procedure, I think it would be good to give a lot of information. It makes a lot of difference. Some of it is just some one line and you really don't know. So bringing the patient for consultation. The patient is coming for procedure, he's been booked for 9, coming in at 10 and all that. And it's very difficult. But if you had a good discussion, you can even send a something soft or call so that we can all understand the patient. Because sometimes there are a lot of hidden things that we really don't know. And like I always say, so you see them in pairs. But I saw this probably 3 years ago, and just this year I had another. This one is adult, full blown adult. This one was 24, but this one was like 54. That's one of the toothpick. And toothpick, the other thing, you know, he can't even remember, but he does what he always used to do. He has no idea when he's not going to. And toothpick has 2 sharp ends, so please don't advise them that it will pass. It will not. It's not a plastic pen, it's not smooth, and the two, all of them can cause lots of injury. I summarize it here, but if you read it for complication or something, let them know more about it. So don't advise or don't tell that, but immediately get to the ears and so that it can be taken out. Okay? The advice is that they will come and know. I think I need to learn some video editing. So that I go straight to the issues and stick it and bring it to. I was hoping to move it. So that's the toothpick I showed you earlier on. Okay. So it's not just a photo. So what happens is that when there is peristalsis, pierces on the opposite side, very painful. So it's causing damage to that side. That's the pain that is being complaining. And it started migrating. It's not lying free in the stomach. It started migrating. And you realize that what we see outside here is about 1/4 of it, about 2, how do you call it? 3/4. It means it was gradually migrating. In the wall, in the antrum of the stomach. So this is the antrum of the stomach. What I was saying is penetrating. So it's not open, it is penetrating here. This was a grasping fossa. So that's what I'm saying. Look at the extent that was. But the technique is that if you leave it freely like this, as you come through the esophagus, it can also pierce on that side. So you would have to know, so you have to bring it all the way to the end of the scope. Okay? So that you can easily move it. It's not in any textbook, but just by thinking about it. Because if you hold it freely and you come through the esophagus, it's also closed. You are likely to perfect it. So bring it very close to the end of the scope. So it's like the side of the scope. Okay, so finally we are starting. So just to see. So look at the extent. So the other end is all in the gradually migrating. And in my search, I mean, sometimes when you see a case, I think you can advise that you can also read around. Initially, I thought, well, there was something that has never happened before, but when I went online to read about it, it's very common. Okay, swallowed toothpick, very common, especially in children, and they have described complications all the way to IVC perforation. So what it means is that you do that one day and hypertension, the ER, they will never be able to die because if you do CT, MRI, they will not pick the wound. The wound will not light up. The patient will die. So it's one, exactly. Difficult to find this appeal. Unless you dissect the whole IVC to really make a diagnosis. So my concluding message is that there's a need for urgent endoscopy to remove the toothpick. So don't tell them they will pass. You need to get to the nearest endoscopy center as quickly as possible, and then we can deal with it. Swallowed toothpick has some complications. Bowel perforation, migration into the hepatobiliary system, forming abscess has also been documented, and more worrying perforation of the IVC has also been documented. So know about it and don't over assure your patients in this regard. So thank you very much.